Hello, my name is Brent Reed, and the following presentation is an overview of heart transplantation. Patients become eligible for heart transplantation when they have advanced or end-stage heart failure. Although a strict definition does not exist, patients being considered for transplant have many of the indications listed here, such as severe symptoms that do not resolve with rest, reduced cardiac output, target end organ dysfunction, or an inability to tolerate evidence-based therapies. There are only a few absolute contraindications to heart transplantation, such as irreversible pulmonary hypertension and active malignancy. The remainder are relative contraindications and are either often patient or institution specific. When patients are listed for a heart transplant, they are assigned a status which helps prioritize donor organs to those who need it the most urgently. Status 1A patients are critically ill and require advanced measures to remain alive. Status 1B patients also require advanced therapies, but are stable and may even be waiting on an organ at home. Status 2 patients are stable on only oral medications, whereas Status 7 is used to designate those patients who are temporarily inactive due to an acute change in condition, such as an active infection, but still accumulate waiting time on the list. Donor matching is coordinated by the United Network for Organ Sharing, or UNOS. Organs are matched to eligible recipients within geographic regions, although in some cases out-of-region organs may be accepted. Additional criteria used to match donor organs and recipients are blood type, body size, and clinical status. Once a heart has been transplanted, there are many important physiologic changes to consider. First, the donor heart is denervated and therefore unable to respond to direct sympathetic and parasympathetic activation. This may render medications like atropine ineffective and may prevent patients from experiencing heart-related pain such as angina. Temporary sinus node dysfunction is also common, meaning that the heart has decreased chronotropic competence. A goal heart rate of greater than 90 beats per minute is often targeted to maintain adequate hemodynamics. As a consequence, heart transplant recipients often require chronotropic therapies for a period after transplantation, and refractory cases may even require pacemaker implantation. Because of these features, patients are more preload dependent after heart transplantation. Cardiac function may be further compounded by global myocardial depression, which can be ameliorated by minimizing the cold ischemic time, or the time that the organ is outside of the body. Because patients with heart failure often have elevated pulmonary pressures prior to transplant, great care must be taken to prevent right ventricular failure of the newly implanted organ. Patients may therefore require aggressive diuresis or the use of pulmonary vasodilators to reduce pulmonary pressures for a period of time after transplant. Finally, patients with transplanted hearts are susceptible to cardiac allograft vasculopathy, a type of coronary artery disease caused by low-level chronic rejection mediated by the host's immune system over long periods of time. Before we discuss immunosuppression therapy, let's briefly review some of the major pathways involved in T-cell mediated immunity. The host response is initiated when an antigen-presenting cell presents a major histocompatibility complex, or MHC molecule, on its surface containing a foreign antigen. There are a number of components of the T cell involved in the cellular response, including the T cell receptor complex, which includes CD3 and CD4, the endoplasmic reticulum, which regulates cytoplasmic calcium concentrations, calmodulin and calcineurin, two intracellular messengers, the IL-2 receptor complex, which includes CD25, mTOR, another intracellular messenger, and CD52, another glycoprotein expressed on the surface of T cells. When the T cell receptor complex binds to the MHC-presented antigen, a number of signaling processes occur, resulting in the release of calcium from the endoplasmic reticulum and increased calcium influx into the cell. The resulting increase in calcium concentrations facilitates an interaction between calcineurin and calmodulin. This complex then dephosphorylates the nuclear factor NFAT, which then migrates into the nucleus of the cell, where it facilitates expression of the IL-2 gene. IL-2 is then released from the cell, where it binds to the IL-2 receptor complex on the surface of T cells, producing a cascade of intracellular signaling events involving mTOR. Ultimately, this stimulates the cell cycle, resulting in T cell proliferation and cytokine production. Also adding to this process is the de novo synthesis of purines, which are used in both cellular replication and protein synthesis. The immune response can also be mediated by host antibodies. Antigens on the surface of the donor graft cells are recognized as being foreign by circulating antibodies. Once binding to these antigens, donor-specific antibodies can produce cell death through a variety of mechanisms. In addition to directly causing cellular injury, antibodies can also activate the complement system, which can result in cell lysis or the recruitment of additional inflammatory cells. Antibodies can also recruit inflammatory cells on their own, such as mast cells, neutrophils, and natural killer cells. These cells may further propagate the immune response, cause direct cell death, or both. Now that we've discussed the basics of the host immune response, let's review the overall management of heart transplant recipients, which we will discuss in more detail in the slides to follow. The main therapeutic objective is to strike a balance between graft rejection and immunosuppression-related complications. First, each patient must be individually evaluated for post-transplant complications, and a suitable donor must be identified. During the surgery, the host organ is implanted. At this time, the team may administer induction therapy, an intense burst of immunosuppression meant to deplete the host immune response. Following transplantation, hemodynamic support and prevention of acute graft rejection becomes a priority. Since immunosuppression may hamper the body's ability to fend off infections, prophylaxis against opportunistic infections is also initiated at this time. Following the initial recovery period, emphasis shifts to providing just enough immunosuppression to prevent graft rejection while minimizing transplant and immunosuppression-related complications. For most patients, immunosuppression can be gradually reduced over time as the host's immune response becomes attenuated to the donor graft, although all patients will require some level of immunosuppression for life. To minimize immunosuppression-related complications, a combination of therapies with different mechanisms of action are used in heart transplant recipients. Let's review each of these using the previous diagram. Basiliximab is an induction agent with activity against the IL-2 receptor complex. Alemtuzumab, another monoclonal antibody used for induction, has activity against CD52. Anti-thymocyte globulin has been used as both an induction agent and as treatment for acute rejection. Its lymphocyte depleting activity is a result of several mechanisms, some of which are not well understood. The calcineurin inhibitors tacrolimus and cyclosporin are a fundamental component of chronic immunosuppression, as are the antimetabolites mycophenolate and azathioprine, which prevent de novo purine synthesis. Corticosteroids suppress gene expression and are used in the initial immunosuppression regimen for all patients, although attempts are made to minimize them over time. Finally, the proliferation signal inhibitors, sirolimus and everolimus, inhibit mTOR, preventing the immune processes dependent on the cell cycle. The immunosuppression regimen used in heart transplant recipients is comprised of several core components. First, the use of induction is optional, and the duration of its effects are dependent on the agent selected. The effects of basiliximab only last for several weeks, whereas alemtuzumab's effects may persist for months. Corticosteroids are initially used in all patients, although an attempt is made to quickly taper them to a low maintenance dose and eventually discontinue them altogether. Antimetabolites are initiated immediately post-transplant and are continued unless the patient becomes intolerant to their adverse effects. Calcineurin inhibitors are used at high serum concentrations immediately post-transplant, but are gradually decreased over time to minimize their adverse effects. For select patients, proliferation signal inhibitors may be substituted for antimetabolite therapy since they have similar mechanisms of action. For patients who develop renal impairment, a proliferation signal inhibitor may be substituted for a calcineurin inhibitor, although this is associated with a slightly higher risk of rejection. Regardless of the regimen selected, immunosuppression therapy must be tailored for each individual patient based on their history of rejection, infections, and other transplant-related complications. As alluded to previously, induction therapy is an optional burst of intense immunosuppression used perioperatively as a strategy in high-risk patients. Excess risk may be due to an increased risk of graft rejection, such as in patients who may be highly sensitized, like those who have received a recent blood transfusion, or it may be due to excess risk of adverse effects from conventional immunosuppression. Examples of this latter strategy include the renal impairment that may occur with calcineurin inhibitors. Many patients with heart failure have pre-existing renal impairment prior to transplant. Induction therapy may permit the delayed initiation of calcineurin inhibitors, which may facilitate renal recovery in the post-transplant period. Induction therapy may also be used to reduce the dose of corticosteroids used after transplant. Regardless of the reason for using induction therapy, it should be performed with caution due to various complications, including an increased risk of infection and hematologic abnormalities such as anemia, neutropenia, and thrombocytopenia. The calcineurin inhibitors include cyclosporin and tacrolimus, although most centers have now transitioned to using tacrolimus as their agent of choice. As mentioned previously, initiation may be delayed in patients who receive induction therapy. In all patients, serum concentration monitoring is used to optimize efficacy and safety. The table shown here represents example goal troughs in heart transplant recipients. As you can tell, higher goals are used in the immediate post-transplant period given the increased risk of rejection, although the goal range in an individual patient may need to be higher or lower based on the level of immunosuppression required. Regardless, the objective is to gradually reduce the goal range over time in order to prevent the risks associated with calcineurin inhibitors, which include renal impairment, hypertension, dyslipidemia, diabetes, among other adverse effects. The calcineurin inhibitors are extensively metabolized by CYP3A4, and the drug-drug interactions that may result from inhibitors and inducers of the CYP3A4 system must be carefully managed in order to optimize the safety and efficacy of these agents. The antimetabolites include mycophenolate formulations and azathioprine. Mycophenolate has become the agent of choice at most centers due to a lower incidence of bone marrow suppression and studies suggesting it may be associated with less rejection. Mycophenolate is available as 2 oral formulations which are not dose interchangeable. Mycophenolate mofetil, also known as Cellcept, and mycophenolic acid, also known as Myfortic. Mycophenolate is started at high doses post-transplant and is usually only decreased in patients who develop infections or intolerance to therapy. Gastrointestinal intolerance and neutropenia are the 2 most common adverse effects requiring dose reduction or elimination altogether. Although serum concentration monitoring can be performed with mycophenolate, it does not correlate very well with efficacy or toxicity and is therefore not routinely recommended. High doses of intravenous corticosteroids are used in the immediate post-operative period. Once the patient can reliably take oral medications, corticosteroids are transitioned to an oral formulation and quickly tapered to a low maintenance dose of around 10 to 20 milligrams of prednisone per day. Therapy is then tapered slowly over time, and many patients are able to discontinue steroids altogether after 1 year. The use of induction therapy may permit a steroid-free regimen, although many patients may still require low doses temporarily. An effort to limit steroid use is made in all patients because they account for many of the complications observed in post-transplant patients, shown in the table to the right. Because adverse effects like hypertension, hyperlipidemia, and diabetes are also observed with other immunosuppression therapies, steroids only compound these risks. Finally, proliferation signal inhibitors such as sirolimus and everolimus may be substituted into the immunosuppression regimen for select heart transplant recipients. They are often avoided immediately after transplant because of their risk of delayed wound healing. However, they are the most effective agents for cardiac allograft vasculopathy, or CAV, a manifestation of chronic rejection that contributes to much of the late morbidity mortality observed in heart transplant recipients. In fact, some centers automatically add or substitute a proliferation signal inhibitor at about 1 year after transplant in order to reduce the risk of CAV. In these patients, it is often substituted for the antimetabolite, although it may be substituted for the calcineurin inhibitor in patients with prolonged renal impairment. Like calcineurin inhibitors, serum concentrations can be monitored to optimize safety and efficacy, and similar caution must be used regarding inducers and inhibitors of CYP3A4. Common adverse effects of the proliferation signal inhibitors include hyperlipidemia, leukopenia, and thrombocytopenia. Now that we have discussed the general management of heart transplant recipients, let's review the management of acute rejection. The management of acute rejection is very center-specific, so the strategy outlined here should only be considered an example. Although very mild cases can be managed in an outpatient setting, moderate to severe cases require hospitalization for more aggressive therapy. First, several types of routine monitoring are performed to identify rejection before it becomes symptomatic. These include periodic endomyocardial biopsies, echocardiography, and right heart catheterization. However, some patients may develop acute rejection in the interim, which often mimics the signs and symptoms of acute decompensated heart failure, including shortness of breath, fatigue, edema, and arrhythmias. Once rejection is suspected, it should be differentiated according to type, which is done using endomyocardial biopsy. Acute cellular rejection, if mild, can be treated with steroids alone. After the acute symptoms have resolved, the patient may be transitioned to a maintenance regimen, although it is often enhanced because the patient's prior rejection was likely due to a regimen that was not strong enough. Moderate to severe cases may require the addition of anti-thymocyte globulin for several days. Again, the patient is eventually transitioned to a maintenance regimen once the rejection has resolved. Antibody-mediated rejection is also classified according to severity. Mild cases are often treated with steroids, although antibody-mediated rejection is less amenable to their use compared to cellular rejection. Moderate to severe antibody-mediated rejection may require plasmapheresis, a process by which antibodies against the donor are filtered from the blood. Because there is no way to differentiate donor-specific antibodies from antibodies required for other immune processes, plasmapheresis is generally followed by supplemental administration of intravenous immunoglobulin, or IVIG. Refractory cases may require the addition of upstream therapy, such as rituximab. As with other types of rejection, patients are eventually transitioned to a maintenance regimen that is often stronger than the one they were on prior to the rejection episode. Even patients who have not had any episodes of acute rejection may be susceptible to chronic rejection, which occurs as a result of low-level immunologic responses over long periods of time. This is most often manifested as cardiac allograft vasculopathy, or CAV, a type of coronary artery disease that differs significantly from what is experienced in native hearts. First, patients are less likely to experience angina due to denervation of heart tissue. Secondly, CAV is morphologically different from typical atherosclerosis. Typical atherosclerosis is characterized by focal lesions, which often result from fatty lipid cores, as shown here. Fortunately, these lesions are often amenable to percutaneous coronary intervention or bypass surgery. However, CAV is characterized by diffuse luminal narrowing due to widespread intimal thickening, as shown here. Because CAV may have a widespread impact on the vessel, revascularization is rarely a definitive solution. Immunosuppression places patients at risk for opportunistic infections. Shown here are some of the most common infections, each of which warrants prophylaxis for a period of time after heart transplant. Antifungal prophylaxis is required for several weeks after transplant to prevent overgrowth of candida due to high-dose steroid therapy. All patients should receive prophylaxis against cytomegalovirus, or CMV, for a period of time after transplant, although the duration of valganciclovir therapy is dependent upon whether the donor and/or recipient was exposed to CMV prior to surgery. The patients at highest risk for reactivation of CMV infection are those where the donor was exposed, but the recipient was not. In these patients, up to a year of prophylaxis may be considered. Finally, transplant recipients are susceptible to PCP and toxoplasma for a period of time after surgery. The combination of sulfamethoxazole trimethoprim effectively covers both, although other options are available in patients with a sulfa allergy. With the exception of acute rejection episodes requiring high-dose steroids or maintenance doses of prednisone that are above 10 milligrams per day, most patients are able to discontinue prophylaxis at a year after transplant. Finally, transplant recipients are at risk for a variety of other complications that are often amenable to pharmacologic therapy. As described earlier, reduced chronotropic competence may resolve on its own. However, patients with persistent bradycardia may require temporary courses of theophylline or albuterol to maintain a heart rate greater than 90 beats per minute. All patients should also receive a statin after transplant, as they have been shown to improve mortality in this setting, irrespective of their effects on lipid levels. Most patients should receive supplementation with calcium and vitamin D to prevent osteoporosis. Other complications of immunosuppression are patient-specific, but still require close monitoring after transplant. The list here includes some of the most common complications. Patients who develop chronic conditions such as hypertension and diabetes following transplant should be managed according to guidelines for those specific disease states. And that concludes today's presentation on heart transplantation. Thank you for your attention.